Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 230 of our pharmacotherapy series, which majors in infectious diseases. Mr. R.O.G., a 63-year-old, 70 kilograms man in the intensive care unit, underwent emergency resection of his large bowel. He has been mechanically ventilated throughout his postoperative course. On day 20 of his hospital stay, R.O.G. suddenly becomes confused, his blood pressure drops to 70 systolic 30 diastolic, with a heart rate of 130 beats per minute. His extremities are cold to the touch, and he presents with circumoral pallor. His temperature increases to 40 degrees Celsius axillary, and his respiratory rate is 24 breaths per minute. Copious amounts of yellow-green secretions are suctioned from his endotracheal tube. Physical examination reveals sinus tachycardia with no rubs or murmurs. Rhonchi with decreased breath sounds are observed on auscultation. The abdomen is distended, and R.O.G. complains of new abdominal pain. No bowel sounds can be heard, and the stool is guaiac positive. Urine output from the Foley catheter has been 10 ml per hour for the past 2 hours. Erythema is noted around the central venous catheter. A chest radiograph demonstrates bilateral lower lobe infiltrates, and urinalysis reveals more than 50 white blood cells per high-power field, abbreviated as WBC per HPF, few casts, and a specific gravity of 1.015. Blood, endotracheal aspirate, and urine cultures are pending. His other laboratory values include the following: sodium levels of 131 milliequivalents per liter. The normal range is from 135 to 147 milliequivalents per liter. Potassium levels of 4.1 milliequivalents per liter. The normal range is from 3.5 to 5 milliequivalents per liter. Chloride levels of 110 milliequivalents per liter. The normal range is from 95 to 105 milliequivalents per liter. Bicarbonate of 16 milliequivalents per liter. The normal range is 20 to 29 milliequivalents per liter. Blood urea nitrogen, abbreviated as BUN, is 58 mg per deciliter. The normal range is 8 to 18 mg per deciliter. His serum creatinine is 3.8 mg per deciliter. It has increased from 0.9 mg per deciliter on admission. The normal range is 0.6 to 1.2 mg per deciliter. Glucose of 320 mg per deciliter. The normal range is 70 to 110 mg per deciliter. Serum albumin of 2.1 grams per deciliter. The normal range is 4 to 6 grams per deciliter. Hemoglobin of 10.3 grams per deciliter. The normal range is 13.5 to 17.5 grams per deciliter for male patients. Hematocrit of 33%. The normal range is 39% to 49% amongst male patients. WBC count of 15,600 per microliter. The normal range is 4,500 to 10,000 per microliter with bands present. His platelet count is 40,000 per microliter. The normal range is 130,000 to 400,000 per microliter. Prothrombin time (PT) is 18 seconds. The normal range is 10 to 12 seconds. Erythrocyte sedimentation rate of 65 mm per hour. The normal range is 0 to 20. Procalcitonin of 1 microgram per liter. The normal value is less than 0.25 microgram per liter. So my question to you reads, which of ROG's signs and symptoms are consistent with infection?
Patient ROG has numerous signs and symptoms consistent with an infectious process. His WBC count, which is 15,600 per microliter, is increased, and a shift to the left, as illustrated by the presence of bands, i.e., immature neutrophils, is observed on the differential. An increased WBC count is commonly observed with infection, particularly with bacterial pathogens. The WBC differential in patients with a bacterial infection often demonstrates a shift to the left owing to the bone marrow response to infection. Although infection is usually associated with an increased WBC, overwhelming sepsis can also be associated with a markedly decreased WBC count. In less acute infection, e.g., uncomplicated urinary tract infection, or a localized abscess, the WBC count may remain within the normal range because less bone marrow response would be anticipated. ROG's temperature is 40 degrees Celsius by axillary measurement. Fever is a common manifestation of infection, with oral temperatures generally greater than 38 degrees Celsius. Oral and axillary temperatures tend to be approximately 0.4 degrees Celsius lower compared with rectal measurement. As a result, ROG's temperature would be expected to be 40.4 degrees Celsius if his temperature had been taken rectally. In general, rectal measurement of temperature is a more reliable determination of fever. Some patients with overwhelming infection, however, may present with hypothermia with temperatures less than 36 degrees Celsius. Furthermore, patients with localized infections, e.g., uncomplicated urinary tract infection, or chronic abscesses may be afebrile.
I would like to add that the bilateral lower lobe infiltrates on ROG's chest radiograph, the presence of copious amounts of yellow-green secretions from his endotracheal tube, and the erythema surrounding his central venous catheter is also compatible with one or more infectious processes. Furthermore, ROG has signs and symptoms consistent with sepsis. My next question to you reads, what signs and symptoms manifested by ROG are consistent with a serious systemic infection? The term sepsis, while a poorly defined syndrome, generally suggests a more systemic infection with the presence of pathogenic microorganisms and/or their toxins in the blood. A uniform system for defining the spectrum of disorders associated with sepsis has been established, but it remains difficult to precisely define. The pathogenesis of sepsis is complex and only partially understood. Gram-negative aerobes produce endotoxin that results in a cascade of endogenous mediator release, including tumor necrosis factor, abbreviated as TNF, interleukin-1 abbreviated as IL-1, and interleukin-6, abbreviated as IL-6, platelet activating factor, abbreviated as PAF, and various other substances from mononuclear phagocytes and other cells. Although this initial stimulus commonly is associated with gram-negative endotoxin, other substances, including gram-positive exotoxin and fungal cell wall constituents, may also be associated with cytokine release. After release of TNF, interleukin-1, and platelet-activating factor arachidonic acid is metabolized to form leukotrienes, thromboxane A2, and prostaglandins, particularly prostaglandin E2 and prostaglandin I2. Interleukin-1 and interleukin-6 activate the T cells to produce interferon, interleukin-2, interleukin-4, and granulocyte macrophage colony stimulating factor, abbreviated as GMCSF. Increased endothelial permeability ensues. Subsequently, the endothelium releases two hemodynamically active substances, endothelium-derived relaxing factor, abbreviated as EDRF, and endothelin-1. Activation of the complement cascade, fragments C3a and C5a, follows, with additional vascular abnormalities and neutrophil activation. Other potentially important agents in this cascade include adhesion molecules, kinins, thrombin, myocardial depressant substance, endorphins, and heat shock protein. The net result of this cascade involves several hemodynamic, renal, acid-base, and other disorders. Uncontrolled inflammation and coagulation have a particularly important role in this sepsis cascade. I will now briefly talk about hemodynamic changes. Critically ill patients often have central intravenous lines in place for measuring cardiac output and systemic vascular resistance. In other words, these lines are placed in the pulmonary artery and allow for more precise measurement of critical hemodynamics. A normal systemic vascular resistance of 800 to 1200 dynes seconds per centimeter to the power of 5, which may fall to 500 to 600 dynes seconds per centimeter to the power of 5 in septic shock as a result of extensive vasodilation. In response to vasodilation, the heart rate increases, leading to increased cardiac output from a normal 4 to 6 liters per minute to up to 11 to 12 liters per minute in septic patients. Stroke volume remains unchanged or decreased. In addition to reflex tachycardia causing a rise in heart rate, stress-induced catecholamine release of norepinephrine and epinephrine also contributes. The initial increase in cardiac output generally is insufficient to overcome the vasodilatory state, and hypotension ensues. In overwhelming septic shock, myocardial depression may result, resulting in a decreased cardiac output. The combination of decreased cardiac output and decreased systemic vascular resistance results in hypotension, often unresponsive to presses and IV fluids. ROG has hemodynamic evidence of septic shock. He is hypotensive with a BP of 70 systolic, 30 diastolic and tachycardic, with a heart rate of 130 beats per minute. This presumably in response to vasodilation and catecholamine release. Although vasodilation commonly occurs in sepsis, this dilation is unequal and chaotic. Some vascular beds constrict and others dilate, resulting in maldistribution of blood flow. In sepsis, blood generally is shunted away from the kidneys, mesentery, and extremities. When sepsis has progressed to septic shock, blood flow to most major organs is decreased. Normal urine output of approximately 0.5 to 1.0 ml per kilogram per hour. That is 30 to 70 milliliters per hour for a 70 kilogram patient, can decrease to less than 20 milliliters per hour in sepsis. The urine output for ROG has decreased to 10 milliliters per hour, consistent with sepsis-induced perfusion abnormalities. Decreased blood flow to the kidney as well as mediator-induced microvascular failure can cause acute tubular necrosis. ROG's uremia as shown by a BUN of 58 mg per deciliter, and increased serum creatinine concentration that is 3.8 mg per deciliter are consistent with decreased renal perfusion secondary to sepsis. Decreased blood flow to the liver may result in shock liver, in which liver function tests, including alanine aminotransferase abbreviated as ALT, aspartate aminotransferase abbreviated as AST, and alkaline phosphatase, become elevated. The liver function tests for ROG are not available, however, his serum albumin concentration is low, that is 2.1 grams per deciliter, and his PT of 18 seconds is prolonged. Decreased blood flow to the musculature classically is characterized by cool extremities, and decreased blood flow to the brain can result in decreased mentation. ROG is confused, his extremities are cold, and the area around his mouth appears pale. All these signs and symptoms provide strong evidence that he is in septic shock. I would also like to briefly touch on cellular changes. The sepsis syndrome is associated with significant abnormalities in cellular metabolism. Glucose intolerance commonly is observed in sepsis, and patients with previously normal blood glucose levels may experience sudden increases in blood sugar. In some cases, a rise in glucose is one of the first signs of an infectious process. ROG's increased blood glucose concentration, 320 mg per deciliter, is therefore consistent with infection. Other sensitive indicators of sepsis-associated inflammation include the erythrocyte sedimentation rate abbreviated as ESR, C-reactive protein, and procalcitonin, nonspecific tests that are commonly elevated in various inflammatory states, including infection. The erythrocyte sedimentation rate, C-reactive protein, or procalcitonin can be used to follow the progression of infection. Currently, ROG's erythrocyte sedimentation rate is elevated at 65 mm per hour. With appropriate management of infection, the erythrocyte sedimentation rate would be expected to decrease. Inadequate treatment would be associated with persistent elevation of the erythrocyte sedimentation rate and C-reactive protein. Procalcitonin is a more specific indicator for infection than erythrocyte sedimentation rate or C-reactive protein, and has been used as a tool to discontinue antibiotics in patients with non-infectious inflammation. At present, ROG's procalcitonin is 1.0 microgram per liter, which is consistent with infection-associated inflammation. Regarding respiratory changes, production of organic acids, such as lactate, increased glycolysis, decreased fractional extraction of oxygen, and abnormal delivery-dependent oxygen consumption are observed in sepsis. This process leads to metabolic acidosis, with accompanying decreased serum bicarbonate levels. The lungs normally respond to metabolic acidosis in a compensatory manner with an increased respiratory rate, that is, tachypnea, resulting in an increased elimination of arterial carbon dioxide. ROG's acid-base status is consistent with sepsis-associated metabolic acidosis. His bicarbonate is 16 milliequivalents per liter, and compensatory respiratory alkalosis due to his respiratory rate, which is 24 breaths per minute. A late complication of the above-mentioned sepsis cascade is acute respiratory distress syndrome, abbreviated as ARDS. ARDS initially was described as non-cardiogenic pulmonary edema with severe hypoxemia caused by right-to-left intrapulmonary shunting resulting from atelectasis and edema-filled alveoli. The primary pathophysiology of ARDS is a breakdown in the natural integrity of the alveolar capillary network in the lung. In the early phase of ARDS, patients have severe alveolar edema with large numbers of inflammatory cells, primarily neutrophils. The chronic phase of ARDS, that is, 10 to 14 days after development of the syndrome, is associated with significant lung destruction. Emphysema, pulmonary vascular obliteration, and fibrosis commonly are observed. Severe ARDS is associated with ratios of arterial oxygen level to fraction of inspired oxygen, abbreviated as PaO2 to FiO2, of less than 100, low lung compliance, a need for high positive end expiratory pressure, abbreviated as PEEP, and other respiratory maneuvers. At present, the treatment for this syndrome primarily is supportive, including mechanical ventilation, high inspired oxygen, and PEEP. If patients fail to show improved gas exchange by day 7, the mortality associated with ARDS is high, that is above 80%. Although ROG currently does not have ARDS, the severity of his sepsis strongly suggests he may develop this complication. Next we will briefly touch on hematologic changes. Disseminated intravascular coagulation, abbreviated as DIC, is a well-recognized sequel of sepsis. Huge quantities of clotting factors and platelets are consumed in DIC as widespread coagulation and inflammation take place throughout the circulatory system. As a result, the ratio of prothrombin time, abbreviated as PT, to international normalized ratio, abbreviated as INR, and the activated partial thromboplastin time, abbreviated as APTT, are prolonged, and the platelet count commonly is decreased in sepsis. Decreased fibrinogen levels and increased fibrin split products generally are diagnostic for DIC. The PT of 18 seconds and the decreased platelet count of 40,000 per microliter in ROG are consistent with sepsis-induced DIC. And lastly, let's comment on neurologic changes. Central nervous system changes, including lethargy, disorientation, confusion, and psychosis, are commonly observed in septic patients. Altered mental status is a well-recognized symptom associated with CNS infections, such as meningitis and brain abscess. These changes, however, are also commonly observed with other sites of infection. ROG's confused state is consistent with that expected with septic shock. And lastly, let's comment on neurologic changes. Central nervous system changes, including lethargy, disorientation, confusion, and psychosis, are commonly observed in septic patients. Altered mental status is a well-recognized symptom associated with CNS infections, such as meningitis and brain abscess. These changes, however, are also commonly observed with other sites of infection. ROG's confused state is consistent with that expected with septic shock.
My next question to you reads, ROG's medical history includes temporal arteritis and seizures chronically treated with corticosteroids and phenytoin. Perioperative, stress doses of hydrocortisone recently were administered because of his surgical procedure. What medications or disease states confuse the diagnosis of infection?
Let's begin with the confabulating variables. Various factors, including major surgery, acute myocardial infarction, and initiation of corticosteroid therapy, are associated with an increased WBC count. Unlike infection, however, a shift to the left does not occur with these disease states or drugs. In ROG, the stress dose of hydrocortisone and his recent surgical procedure might have contributed to the increased WBC count. The presence of bands in this patient, however, strongly suggests a bone marrow response to an infectious process. Next we will discuss drug effects. The ability of corticosteroids to mimic or mask infection is noteworthy. Corticosteroids are associated with an increased WBC count and glucose intolerance with the initiation of therapy or when doses are increased. Furthermore, some patients experience corticosteroid-induced mental status changes that may mimic those associated with sepsis. Although corticosteroids mimic infection, they also have the ability to mask infection. For example, bowel perforation in a patient with ulcerative colitis would result in significant peritoneal contamination. Considering their potent anti-inflammatory effects, concomitant receipt of glucocorticoids may, however, reduce the classic findings of peritonitis. Furthermore, corticosteroids can reduce and sometimes ablate the febrile response. Thus, these corticosteroid-treated patients may be asymptomatic but at great risk for gram-negative septic shock. Another example of the influence of corticosteroids on the diagnosis of infection relates to neurosurgical procedures. Certain neurosurgical procedures are associated with significant trauma to the meninges. However, the patient often is asymptomatic while receiving high-dose dexamethasone, a corticosteroid commonly used to reduce the inflammation and swelling associated with neurosurgical procedures. When the dexamethasone dose is decreased, the patient subsequently may experience classic meningismus, including stiff neck, photophobia, and headache. The lumbar puncture may demonstrate cloudy cerebrospinal fluid (CSF), an elevated WBC count, high CSF protein, and low CSF glucose. Although the signs and symptoms are consistent with infectious bacterial meningitis, if no bacteria grow from the CSF sample, this disease state represents an aseptic meningitis, i.e., inflammation of the meninges without an infectious origin. Certain drugs may cause aseptic meningitis, including nonsteroidal anti-inflammatory agents, sulfonamides, and certain antiepileptics. We will now talk about fever. Fever is also a common finding with autoimmune diseases, such as systemic lupus erythematosus and temporal arteritis, or with sarcoidosis, chronic liver disease, and familial Mediterranean fever. Acute myocardial infarction, pulmonary embolism, postoperative pulmonary atelectasis, and certain cancers are also commonly associated with fever. Factitious fever or self-induced disease must be considered in certain patients. More recent evaluations of fever of unknown origin have resulted in an inability to diagnose the etiology of the fever. In many instances, the fever has resulted in the unnecessary use of antibiotics. After infection, autoimmune disease, and malignancy have been ruled out, drug fever should be considered. Drugs, including certain antimicrobials and antiepileptics, have been associated with drug fever. Drug fever generally occurs after 7 to 10 days of therapy and resolves within 48 hours of the drug's discontinuation. Some clinicians claim that patients with drug fever generally feel well and are unaware of their fever. A re-challenge with the offending agent usually results in recurrence of fever within hours of administration. Drug fever should be considered a diagnosis of exclusion, however, and should be considered only after eliminating the presence of other disease states. In summary, ROG has an autoimmune disease, temporal arteritis, which is known to be associated with fever. Similarly, his corticosteroid administration and phenytoin use may confound the diagnosis of infection. His other signs and symptoms, however, strongly suggest that ROG's problems are of an infectious origin. My next question to you reads, what are the most likely sources of ROG's infection? Independent of the presumed site of infection, in septic patients a series of blood samples for culture tests must be drawn to demonstrate the presence of bacteremia. After blood culture sampling, a thorough physical examination often documents the source of infection. Urosepsis, the most common cause of nosocomial infection, may be associated with dysuria, flank pain, and abnormal urinalysis. Tachypnea, increased sputum production, altered chest radiograph, and hypoxemia may direct the clinician toward a pulmonary source. Evidence for an infected IV line might include pain, erythema, and purulent discharge around the IV catheter. Other potential sites of infection include the peritoneum, pelvis, bone, and CNS. ROG has several possible sites of infection. The copious production of yellow-green sputum, tachypnea, and the altered chest radiograph suggest the presence of pneumonia. The abdominal pain, absent bowel sounds, and recent surgical procedure, however, suggest an intra-abdominal source. Further, the abnormal urinalysis that is above 50 WBC per HPF, and the erythema around the central venous catheter suggest urinary tract and intravenous catheter infections, respectively. My next question to you reads, what are the most likely pathogens associated with ROG's infection or infections? Patient ROG has several possible sources of infection and likely pathogens. Bacterial pneumonia is caused by various pathogens, including Streptococcus pneumoniae, Enterobacteriaceae, and atypical pathogens, e.g., Legionella pneumophila. However, empirical antimicrobial therapy directed against all the above organisms is not necessary in all patients. Community-acquired pneumonia in normal hosts is generally associated with bacterial, Streptococcus pneumoniae, Haemophilus influenza, and atypical bacterial pathogens. In contrast, nosocomial pneumonia, that is those acquired in hospital or in other healthcare facilities, e.g., nursing home, is associated with gram-negative bacilli, e.g., Escherichia coli, Klebsiella species, Enterobacter species, and Pseudomonas aeruginosa and Staphylococcus aureus. If the pneumonia is a result of a gastric aspiration, empirical antibacterial treatment of mouth anaerobes generally takes place, however, their true pathogenicity in aspiration pneumonia is not clear. For the empirical treatment of hospital-associated pneumonia or ventilator-associated pneumonia, knowledge of a hospital epidemiology is useful. If Pseudomonas aeruginosa or Enterobacter cloacae predominate in an institution, then broad-spectrum agents should be used directed against these pathogens. Similarly, prior or concurrent receipt of antimicrobial therapy significantly impacts the choice of empirical therapy. Age is an important determinant in the epidemiology of infection. For example, meningitis in a neonate is commonly caused by group B streptococci, Escherichia coli, and Listeria monocytogenes, whereas these bacteria are uncommon meningitis pathogens in normal adults. The presence of concomitant diseases, such as chronic obstructive pulmonary disease (COPD) or alcohol and IV drug use, also influences the specific pathogen. As an example, patients with COPD-associated pneumonia are more likely to be infected by Streptococcus pneumoniae and Haemophilus influenza, whereas chronic alcoholics are more likely to have Klebsiella species as a source of pneumonia. Immune status is an important predictor of likely pathogens. HIV/AIDS patients or those receiving anti-thymocyte globulin abbreviated as AT-GAM, cyclosporine or tacrolimus, sirolimus, and corticosteroids have lymphocyte deficiency or dysfunction-associated infections, including those caused by cytomegalovirus, Pneumocystis jirovecii, atypical mycobacteria, and Cryptococcus neoformans. Patients with leukemia and neutropenia are at risk for infection caused by aerobic gram-negative bacilli, including Pseudomonas aeruginosa, Candida species, and Aspergillus species, as well as the above-mentioned pathogens. In ROG, the abdomen, respiratory tract, urinary tract, and IV catheter are all potential sites of infection. Intra-abdominal infection is likely caused by aerobic gram-negative enteric bacteria, Bacteroides fragilis, and possibly Enterococcus. Nosocomial urinary tract infection is usually caused by aerobic gram-negative bacteria. ROG's pneumonia could be attributable to gram-negative bacilli and staphylococci, as well as other organisms. Furthermore, his long-term use of corticosteroids may predispose him to infection caused by more opportunistic organisms, including Legionella, Pneumocystis jirovecii, and fungi. Lastly, his IV catheter infection suggests infection caused by staphylococci, including Staphylococcus epidermidis and Staphylococcus aureus. My next question to you reads, a gram stain of ROG's tracheal aspirate shows gram-negative bacilli. What tests may assist with the identification of the pathogen or pathogens? Once the site of infection has been determined and host defense and other epidemiologic factors have been evaluated, additional tests can be performed to identify the pathogen. The gram stain uses crystal violet solution and iodine staining bacteria gram-positive or gram-negative. Some organisms are gram-variable. In addition, the shape of the organism, that is cocci or bacilli, is readily apparent with the use of the gram stain. Streptococci and staphylococci are gram-positive cocci, whereas Escherichia coli, Enterobacter cloaca, and Pseudomonas aeruginosa appear as gram-negative bacilli. If the gram stain of the tracheal aspirate demonstrates gram-positive cocci in clusters, empirical antistaphylococcal therapy is indicated. In contrast, if the gram stain shows gram-negative rods, antimicrobials with activity against these pathogens should be used. Similar to the gram stain in bacterial infection, the India ink and potassium hydroxide stains are helpful in the identification of certain fungi. The acid-fast bacilli stain is critical in the diagnosis of infection caused by Mycobacterium tuberculosis or atypical mycobacteria. In ROG's case, the gram stain suggests that antimicrobials active against gram-negative bacilli should be used. Next we will discuss culture and susceptibility testing. Culture and susceptibility testing provides final identification of the pathogen, as well as information regarding the likely effectiveness of various antimicrobials. Although these tests provide more information than the gram stain, they generally require 18 to 24 hours to complete. After the pathogen has been identified. We will now briefly touch on disc diffusion. The most widely used tests for bacterial susceptibility are the disc diffusion and the broth dilution methods. The disc diffusion, that is the Kirby-Bauer technique, uses an agar plate on which an inoculum of the organism is placed. After inoculation, several antimicrobial-laden discs are placed on the plate, and evidence of bacterial growth is observed after 18 to 24 hours. If the antimicrobial is active against the pathogen, a zone of growth inhibition is observed around the disc. Based on guidelines provided by the Clinical and Laboratory Standards Institute, abbreviated as CLSI, the diameter of inhibition is reported as susceptible, intermediate, or resistant. CLSI zones of inhibitions are determined taking into account known achievable antibacterial concentrations. However, broth dilution determination of minimum inhibitory concentration better links with achievable antibacterial concentrations. Next we will discuss broth dilution. The broth dilution method involves introducing a bacterial inoculum into several tubes or wells filled with broth. Serial dilutions of antimicrobials, e.g., nafcillin 0.5, 1.0, and 2.0 micrograms per milliliter, are placed in the respective wells. After bacteria are allowed to incubate for 18 to 24 hours, the wells are examined for bacterial growth. If the well is cloudy, bacterial growth has occurred, suggesting resistance to the specific antimicrobial at that concentration. As an example, if bacterial growth is observed with Staphylococcus aureus at 0.5 micrograms per milliliter of nafcillin but not at 1.0 micrograms per milliliter, then 1.0 micrograms per milliliter would be considered the minimum inhibitory concentration (MIC) for nafcillin against Staphylococcus aureus. Similar to the disk diffusion method, the CLSI provides guidelines that also take into account the pharmacokinetic characteristics of an antimicrobial to determine whether the MIC should be reported as susceptible, intermediately susceptible, or resistant. MIC interpretations are both pathogen and antimicrobial specific. For example, ciprofloxacin achieves serum concentrations of only 1 to 4 micrograms per milliliter, whereas the fourth-generation cephalosporin, cefepime, achieves peak serum concentrations of 75 to 100 micrograms per milliliter. Consequently, an MIC of 4.0 micrograms per milliliter for Pseudomonas aeruginosa would be interpreted by CLSI as resistant to ciprofloxacin but susceptible to cefepime. Although these tests provide an accurate assessment of in vitro susceptibility, the time delay 18 to 24 hours can hinder streamlining of therapy. An alternative efficient, but more expensive, MIC test is the E-test, which uses an antibiotic-laden plastic strip with increasing concentrations of a specific antimicrobial from one end to the other. The strip is placed on an agar plate with the actively growing pathogen. Inhibition of growth observed at specific marks on the strip coincides with the MIC of the organism. Numerous studies have confirmed that the E-test is as effective as traditional susceptibility testing. Several automated antimicrobial susceptibility systems are available in the United States, including Phoenix from Becton Dickinson, Franklin Lakes, New Jersey, Vitek from bioMérieux, Durham, North Carolina, MicroScan Walkaway from Siemens Healthcare Diagnostics, Tarrytown, New York, and Sensititer from Trek Diagnostics, Cleveland, Ohio. These systems generally use a computerized algorithm for interpreting results and determine the antibiotic MIC for the organism by using specialized decision technology. Two major advantages of automated susceptibility methodologies include a reduction in labor and faster reporting of susceptibility results, potentially leading to the earlier initiation of appropriate antibiotic therapy. Although these represent advantages, disadvantages exist, particularly with cystic fibrosis isolates. Most clinical microbiology laboratories use automated susceptibility testing systems. While these automated antimicrobial susceptibility systems are an improvement over traditional broth dilution and disk diffusion methods, other emerging technologies including PCR and other next-generation systems are likely to result in more rapid identification of pathogens and their associated antimicrobial susceptibility. Although susceptibility testing is relatively well standardized for aerobic gram-negative and gram-positive organisms, its utility is not as established for anaerobes and fungi. In general, despite improvements in the standardization of testing in anaerobes, institutions do not routinely perform susceptibility testing for these bacteria. In contrast, susceptibility testing is now available for Candida species, and these in vitro data have been demonstrated to predict clinical success in the patient care setting. The consensus of the CLSI and other experts is that anaerobic isolates from blood, bone and joint sources, brain abscesses, empyemic fluid, and other body fluids that are normally sterile should be considered for susceptibility testing. However, in general, these susceptibilities are rarely performed. Progress has been made in developing a standardized test for determining fungal susceptibility, but the primary emphasis has been on the susceptibility of Candida species to azoles in the treatment of candidiasis. Although standardized susceptibility testing for molds is established by the CLSI and other organizations, the correlation with clinical outcome is variable. The best correlation between antifungal susceptibility testing and efficacy lies with the use of azoles in the treatment of disseminated aspergillosis. The next question reads, Serratia marchescens grows from a culture of ROG's endotracheal aspirate. How can it be determined whether an isolate represents a true bacterial infection versus colonization or contamination? A positive culture may represent colonization, contamination, or infection. Colonization indicates that bacteria are present at the site, however, they are not actively causing infection. Poor sampling techniques or inappropriate handling of specimens can result in contamination. Contamination differs from colonization in that these isolates are not truly at the site in question. The Serratia marchescens growing from ROG could represent infection, colonization, or contamination. If a suction catheter was used to sample ROG's endotracheal aspirate, the infecting organism likely would be cultured. However, other non-pathogenic flora would also appear in the culture medium colonization. Furthermore, if the sample is not handled aseptically by the clinician or the microbiology laboratory, bacterial contamination is possible. In summary, culture results do not solely identify true pathogens. In ROG, the Serratia may be a pathogen, contaminant, or colonizer. Nevertheless, considering the severity of ROG's illness and his associated respiratory symptoms, treatment directed against this pathogen is necessary. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arora, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 231 of our series.